You know, like you go to holiday.
But you don't
have them in a package of soap. Oh, no, the holidays are much better. I would never have such a thing there. What I
Oh.
Yeah, I started the recording, but
and I didn't know I'm living in 30 miles from here.
me too.
It's working.
Website,
I think
Grace is
You know, I'm not saying that.
You do need to do like
My daughter's.
but it finds more text.
Oh.
So that's what I'm I didn't know like after
give a couple minutes or
I just wait like 2 minutes. That's the so usually I just go after recording.
Maybe I should have.
Bring it to Tracy. So if you want to just check back after, make sure I have everything else.
That is so huge. Thank you. Oh, yeah. There's no getting these laws because we also have to hear that this is.
Nothing's right now. It usually gives me a little buzz.
Oh, so sorry. I knew I didn't have it. Okay.
When I went to an extra,
Great. That was a new drive. It was
empty. Nancy might have some. Nancy, do you have batteries? I'm gonna bring some.
batteries. And it's like, what size? It's like.
Double, triple A, two triple A's.
Combination.
Yeah, there's one on here.
It's a variation on the theme. Mexican Village is also one of our faves. Well, I just was there the other day.
We're waiting just a couple minutes.
Just batteries and you know, when you get to like sometimes you get confused. Like when I first used to come out to visit relatives and they'd say barbecue, we're gonna have barbecue.
No students.
Okay, barbecue means something very
Good, then we
different.
won't get anybody else in that.
Because I thought walking in the house and it's like, oh, you meant sloppy joes. Or like hot dish, right? Hot dish, you know, we have some, we make some food like that, we call it casserole. Of course, right. I have to put those on back, but I never had a
I'm like, and
It's
feel like
salad until I got out
would
here.
be awkward.
I
I
don't
don't like that.
What the heck? How can you even call this a salad? I don't like that at all.
They would know these things.
I heard from other people, anyway.
Yeah, you just have to like take a deep breath.
Oh,
Sherry got down there.
Fancy.
Yep.
Yes.
Thank you.
There we go.
Words, Darlene.
It is a lot of.
Usually that happens, I have like bites out of my apples. That's good.
Did you realize that the state has but it'll soon be it's down They skip the food.
They go right to the good stuff.
Yeah, that was tough.
Oh,
Did
man, I
somebody-
didn't even think of that.
Take the little gizmo that operates this, that's usually on the bottom of this. We have another one in the room next door.
Is it not working?
Well, you have to have the,
Well, the turn it down.
you have to have the part that goes in here plugged into the computer.
Oh.
Plugged in anywhere, and it's not advancing slides. So.
Is your mouse, no, here, try it now. You have to have your mouse on the right screen. That sometimes helps.
It is work. Oh, yeah.
That's usually the problem.
I can't see where they put the little gizmo.
It might be under that.
Might be
Block 8.
stuck in. Okay. All right, so ready to go. Can we go? Can I start? I don't need to introduce myself. I think everybody knows me.
Usually I do, but it's okay.
Okay. Okay, so my presentation is on promoting IPEC and telehealth competencies using, and if you get the acronym, remotely operated BiO, the O is capitalized, that's not spelling error, that's part of robots. So it's remotely operated BiOmedical telepresence systems in longitudinal continuity of care simulations. So I'm actually giving a presentation that was developed by Dr. Richard Van Eck, so I've tried to personalize it so that I can understand his way of writing up a presentation. So that's so it'll be a little fuzzy when we get to some of the statistical slides, but I think that it'll go just fine. I want to thank anybody in the room who's ever participated in an interprofessional sim, because we've had a lot of fun doing these simulations at UND, and we've been doing them for quite a few years now. And I looked back through our annual reports and found that the earliest one that I think that we did is in the fall of 2013, and that was a trauma sim that we participated in. Then we had a little gap, and since that time we've had multiple we call them simulation-based interprofessional education experiences, or if you see SIM IPE in the literature, that's what we're referring to. So just in the last couple of years, we've introduced robots into the experiences, and that's mainly what I'm going to talk about today, and we've participated in 5 of those robots experiences. Recently also we've added more disciplines. So we started with just nursing and medicine, and we've gradually added more disciplines and hoping to add more as time goes on. So why do we do SIM and why do we do interprofessional experiences? According to our accreditors, we need to do this so that we can help promote patient safety. So in our, I don't need to read through each of these, but these are some of the actual lines that come from our accrediting body, CCME, that tell us that we need to use telecommunication technologies, or our baccalaureate graduate needs to use telecommunication technologies. They need to be able to use inter and intra-professional communication. They need to be able to communicate effectively with members of the healthcare team, and they need to contribute and compare their roles and perspectives with other healthcare professionals. And we're seeing a lot of that in these interprofessional SIMs. So it's been really good to participate in these. The big thing about simulation and why not just interprofessional education by other means is because they can practice the skills in a safe environment within a simulation. And the basic background. Sure.
So you mentioned that this is a requirement for the accreditation body. What proportion of those training has to be
So far, there's no legislation that says we have to do a certain percentage. We have a report that says we can do up to 50% of our clinical experiences in simulation without it having an untoward effect with the graduates or untoward effect with board scores. But we don't. There's nothing that says you have to do a certain amount in SIM or have to do a certain amount of hours.
Because it varies a lot between the different colleges.
Yes, definitely. One of the reasons that I think it's important for us to continue to do this is one of our experiences early on. We had 4th-year med students who were being facilitators. You know, they were in the role of a medical faculty person. And one of the 4th-year students said that in all his years of education as a medical student, he had never thought of introducing himself to the nurse at the bedside. Never referred to her with a name. He said he had always thought of her as just the nurse. And that to me gives me really big impetus to keep moving forward with this, because we need humans treating other humans in a way where they know each other and communicate effectively. To me, I think about being the patient in the bed, and if that doctor says, okay, I'm leaving your care to Christy, instead of I'm leaving your care to the nurse, and he knows who Christy is, and Christy knows how to get a hold of that doctor. To me, that's a world of difference than somebody who just says, okay, yeah, the nurse has got this, and they'll take care of you. I think that personal touch is so important. So I don't need to belabor this, but we've been doing NG labs and Foley catheterization labs with the med students for almost 20 years now, I think. Missy and I were trying to remember back, and I think 2001 is as far back as we can see it. So we've been doing that for a lot of years where we're kind of learning, we're actually teaching the med students in that instance. In this case with the simulation scenarios, we're learning together, which is important in terms of the definition for what's interprofessional education. So 2016, we had a bunch of faculty, Pat probably remembers this, lots of faculty, staff from the Sim Center, and Dr. John Allen and us working together, and we developed one sim that took us, oh my gosh, how many hours to create it?
We know it would be worth it then.
Because we had to decide on every single thing that went on with this scenario, and we've learned a more streamlined approach to how to do that since that time. But we had a lot of argument about what do nurses do in the sim, what do the med students do in the sim, because our sims here are set up totally differently than at the med school. Usually the med students come into the room with no knowledge of what's gone on beforehand. They have to diagnose the case. So they don't want to know anything until they get there, and they want them to develop a diagnosis. Our nursing students go into the sim with a lot of pre-information about the diagnosis so they know what cares that patient needs. And so we had to come up with compromises when we did the sims together to think about how much of the nursing role in the sim needed to be about actually doing the skill, or how much of it just needed to be communication or collaboration. So we backed off a little on the skills, which maybe now there's more talk, maybe we'll put a few more in so that med students get to see the kinds of skills that nurses do and vice versa. But the time limits us sometimes to what we can accomplish in a half-hour simulation period. So anyway, we've done breast cancer, end-of-life, CHF, and MI sims, and now we've added the robot sims, and I'll tell you more about each of those. Okay, you thought there were a lot of words on that first slide. This is just background for the particular study that the med school did in regard to the robot simulations. So because of rural health having some unique challenges like distance and access to a physician's services, and because we have less physicians in the rural settings with a lesser ratio of patient to physician in rural settings than we do in urban, there's a lot of reason that we need to get access to physicians from a remote site. So places like, I'm from Kenmare. I think of Kenmare and Stanley and Bowbells and some of those areas where people would come into a remote ER with an MI, but need to be transported somewhere quickly for cardiac support. That's what we were enacting with our first robot scenario when we worked on this together. So there is a shortage of physicians. There's, of course, the shortage that we know in nursing. We need to continue to prepare baccalaureate nurses to practice in those areas and beyond baccalaureate degree to practice in rural areas. And they need to have telehealth knowledge in order to get that care to the patients that they need. So because people in remote settings need telehealth to communicate, in urban settings they use telehealth as well, but they have the advantage of having what we call collocated professionals working together. They can congregate a specific group of people together to do that care. We don't have access to the same kinds of people in the rural settings. So we don't have as many specialties on site. So technology is one new way to bridge the gap for rural areas. And telehealth in this case may enhance care delivery by supporting the interactions. But what we want to address are the inherent challenges that come along with learning how to use telehealth in those settings. You can't just pop it into the rural settings and expect that people know how to use it and use it effectively. So the health professionals go to those areas require training. So our objective for the robot sims was to develop a series of longitudinal continuity of care simulations, meaning 3 sims over time that all dealt with the same patient who was experiencing care for the same condition in different settings. So We wanted to promote IP competencies, interprofessional competencies, mostly communication and collaboration, and integrate telehealth in low resource settings. So the other thing that we did as a result of doing this, there's a lot of tools that you can use to measure interprofessional interaction in a simulation. One is the CATS tool, but everybody's using a different tool. But there's not a tool that we found that could assess telehealth. So we wanted to adapt the CATS tool to incorporate telehealth so that we could measure that as well. And I'll show you what we added to that CATS tool to make that possible. We did 3 interprofessional telehealth educational simulations, and we did those in fall of 2017 and fall of 2018, where we had healthcare students in 5 disciplines, same patient, different settings, different time, and they were progressive. So it was Millie Anderson, right? Do I have to? No, different. Alice Horton was in 3 different settings. 3 different. Yeah. Okay. So we host this at the UNB School of Medicine and Health Sciences Simulation Center, where they have 6 rooms that they can run at once. We had 5 disciplines participating, and our focus was on communication and collaboration. And we adapted this from the med students all had a place in their curriculum already for a cardiac simulation, so we used a cardiac case for this. The way this schedule works, we have 6 rooms that run simultaneously, which takes quite a bit of personnel because you have, and I'll show you the schedule of how that looks here in a little bit. It's a 4-hour afternoon session. So you have 6 rooms running for the first hour, 6 rooms, second hour, third, fourth, fifth, sixth. So we have 24 scenarios that we're running between 1 and 5 p.m. in the day. Each discipline had to come up with their own objectives and shared objectives, and then convey the pre-briefing information to their particular students. And then once we were running the simulation scenarios, we did joint facilitation. So we started off with a medical and a nursing facilitator in each room with the students as they're in the room. So, and in each of these sims, we hired standardized patients for the role of either the patient in the bed, because in the med school, they also do that part differently. Their standardized patients play the role of the patient through and run the computer vitals for that patient. And then they often have a standardized patient at the bedside that's a family member. So in the first scenario, we didn't have a standardized patient family member at the bedside, we had just the patient. And then the second and third one, we had a family member present as well.
So what does the 5 disciplines include?
Oh, nursing, OT, PT, social work, and medicine. Don't have nutrition there yet. You got to get nutrition involved in these.
That's what I was looking for.
Yeah. So this is kind of a further layout. What did you say? I missed that.
I'm saying that why he's asking.
I was looking for that.
So this just shows how many numbers of students, and this kind of evolved over time. So in our first scenarios, we had the nursing and medical students. In the second scenario, we added quite a few. This one was staged to be a patient care conference. And then the third one was a long-term care scenario where the patient, I'm sorry, I'm lasering people across the room, where we, for the final one was in a long-term care setting. So, and I'll show you some pictures of each of those. Nursing wasn't able to participate in the third one in the first year, but we did in the one this in 2018. So scenario 1, the lady comes in, Alice comes in, she's got chest pain, pressure in the center of her chest, she's been short of breath for 2 days, and she's eventually diagnosed with a myocardial infarction. The way we run that, we have the nursing student come into the room and do like a ER assessment. So the nursing student's in the room just briefly for about 10 minutes with the patient. They assess her, And then when the team of medical students come in, she gives them an SBAR report and talks to them about what she's found with this patient. Then they eventually diagnose her with a myocardial infarction, but they can't do the care there because they're in a rural setting and they need to figure out how to get her the care that they need. So we have the robot in the room that's basically an iPad and it's on a stick with wheels. So you saw a picture of it on that first slide. And that's their cardiologist at a distance that consults with the students about what they should do with this lady, what prep does she need before she gets transferred off. That one was medical and nursing students. And the way, okay, so we don't have a cardiologist that can be a cardiologist during the sim, so we had to train nursing and medical faculty. We gave them a script. They sat in a debriefing room with a camera, you know, kind of like you're doing FaceTime with the room. So they sat in the debriefing room with a script that says, here's what meds she needs, and we need to get her transported. What does she think about it? Can I talk to the patient? And all of that kind of stuff was the script for the cardiologist from that room. So then the robot in the room would interact with the students and the patient in the room. Does that make sense? Questions on that part? Okay. So this just shows a couple of people out in the debriefing room that are sitting at a computer. They're able to view the room and what's going on inside the room. And then you've got the people that are at the bedside of the patient with the nursing student and medical student in that room doing it. So the telehealth role initially was managed by medical and nursing faculty. And then for scenarios 2 and 3, we put medical students in the role of either a cardiologist or primary care physician outside the room in that debriefing room. Scenario 2, Alice gets a little worse, but she's at home and she's not thriving, and a home care nurse knows what she needs in terms of her care. So the home care nurse initiates a care conference, and her family member is present at that care conference. It's a standardized patient in the role of a care conference. And then we had medical, nursing, social work, OT, and PT who also were aware of what was going on with her out in that home setting. So in this case, the medical students interacted in the role of the off-site primary care physician. Scenario 3. I just have to give credit to my mother for making me optimize. Scenario 3 was in long-term care, and the recommendation for her at this time is Alice is getting a little worse, okay? So if the students had an opportunity to see Alice in all 3 of these, they would see that decline. But in nursing, because we can't get 50 students through that scenario each time, and because our clinical sites didn't necessarily want to have students leave clinical to do it all 3 times, they only saw a couple of these scenarios with Alice. The med students saw her each time going through that progression. So in the 3rd scenario, in long-term care, it was the role of the students to discuss advanced care directives, recommend palliative care, symptom management, and telehealth was played by the med students. So again, we had telehealth involved in this. So overall, we had 339 students from 5 different professions in 2017 and 2018. And the instrument that we used was the modified CATS. We call it the CATS-T with that technology component. And so it measures those 4 components: coordination, situational awareness, cooperation, communication, and then 5 items were added to measure telemedicine. The CATS tool is best used when you're reviewing the scenario after it's already been played out. So it wasn't done in real time. It was done with recorded scenarios after the experience. Qualitative analysis was also done primarily from taking quotes and words from students during debriefing sessions. And so far, they haven't finished the analysis. And I can't say I participated in any of the quantitative or qualitative analysis. That's been done by Dr. Van Eck, Dr. Allen, and Eric Johnson, Dr. Eric Johnson at the med school. So they've finished about half of the data. There's more to be analyzed. So what they found with the CAT scores is that if you're looking just purely at competence for overall, when you combine situation awareness, coordination, communication, all of that, overall, it looks like our students are reaching a level of competence if we consider 75% to be our level of mastery. So that's a good thing. I mean, it's showing that our students are doing well with this. When you break it down and you look at competence over each of those components, like coordination, situational awareness, cooperation, there is a difference from scenario to scenario, and there is a difference between the different skills. So, the mastery or 75% level, we didn't achieve that for everything, every time overall on the average. Scenario 3 scores have the highest level of mastery if you look at the yellow bars. Scenario 3 was highest, and we think that was somewhat because of the comfort level that they achieve over time in the scenarios and comfort level with technology. But there could be other factors in that we still need to pull out because of the needing to analyze more data. The least competence was demonstrated in telemedicine. So, which to us is okay. We didn't expect them to come into the scenarios and know exactly how to use it because a lot of them hadn't had a lot of introduction to telemedicine. So it showed to us there is a need for teaching our students about telehealth so that they can get better at it. And the thing that we really noticed with this one, what this is telehealth scores when with no telemedicine and telemedicine. When we looked at the attributes of coordination, situational awareness, cooperation, communication, and compared it when they had no telemedicine versus telemedicine, they lose track of what's going on with the patient scenario when the telemedicine component comes into the room. So their scores on each of those goes down when they initially have telemedicine happening. So they weren't coordinating as well. They weren't as aware of what's going on in the situation. Cooperation was still really good, really high levels of competence with that. But communication with each other declines when that telehealth comes into the room. And there's a lot of reasons why that could be occurring. It could be placement of the telehealth, that it's away from the patient so they don't see the patient at the same time that they're looking at the telehealth. It could be because they're focusing on hearing or seeing the person on the other end of that screen. But we need to do more work with telehealth so that it doesn't interrupt, so that the patient scenario, the care of that patient goes on during that. I don't know if any of you have been in an ER when they consulted telehealth for some of the, like for stroke patients and stuff. Have any of you been in an ER and witnessed that? Because people say that is a kind of a disruptive thing that goes on in an ER setting. They can, other patients can hear what's going on, and so their attention is a little diverted to, because it's loud and coming over the speakers and stuff. Anyway, so the thing that we noticed too is that in the planned versus emergent part of that means in scenario 2 and 3, the camera was set up, ready to go, and interacting with the students the whole time that they were in the room. In scenario 1, when she developed the heart attack, they had to call and request for telehealth to come in, so that we're calling that the emergent telehealth. So when they had to request the telehealth, scenario 1 situational skills were different. And I have to qualify this and say this is totally scenario 1 CAT scores. For the rest of the scenarios, the scores were better. So overall, students exhibited mastery for about, if you look at the ones that are in green on here, those are the scores that are well beyond the 75% or close. I guess we have 73, 74 in there. But the scores for SBAR, closed loop communication, using the microphone, interacting with the camera, those scores were all at really nice high levels of mastery. And a lot of the other scores approached mastery. So 7 of the behaviors, which ones are those? The yellow, approach mastery. And there were lower scores on 10 of the behaviors. So we want to take a look at all of this behavior or all of these results and see what other changes we might need to make in their education to address this. Did I shut this off or why did it quit working? There we go. Here's the fun part, the qualitative analysis from these interviews and from group debriefings. The transcriptions of all of the debriefing sessions were coded and organized into themes. And the headings were developed into 4 major themes. So those 4 major themes related to telehealth, simulation and scenario experience, telehealth simulation roles and relationships, technology and simulation value. And I'll give you some examples of quotes for each of those themes. Okay, so theme 1 related to the simulation itself and the scenario. Students reported that most had little experience and little confidence. Rehearsal and practice of the experience itself reduced their anxiety and boosted their confidence levels. In regard to telehealth protocols, they realized that telehealth requires a different set of skills and requires training. Where I think they came into the scenarios thinking, oh, we know how to do this, and realized during the scenario that they did need some training on this component. They felt that the longitudinal design was a good thing and that telehealth prepared them for the real world, showed them things they wouldn't otherwise get during education. In regard to simulation roles and relationships, they perceived that they had gaps in knowledge and misconceptions of other professions' roles. So this did bring an awareness to them that they needed to learn more about what other people do in healthcare. The simulation experience remediated and changed those perceptions. Students also saw their own roles a little differently as a result of working with others. And one of the things I think about that comes to mind for that is a student who did the assessment of the patient, reported off to the physician. The physician came in and did exactly the same thing that she did. She was furious. She came out of the sim room and she said, I told him what I found. Why did he have to listen again? Why did he have to do everything over that I just did? And so she really didn't understand what we do differently, and that physicians need to confirm those findings for themselves. And so it was kind of an awakening for her as far as what her role is and what the doctor does when he comes in. Seeing each other's expertise in action created respect and appreciation. So they found, they reported collegial relationships with the other professions. In regard to technology, they reported they didn't know where to look, how to make eye contact, and one of the things that we had to teach them about is looking at where the camera is placed on the screen rather than looking at the people that are on the camera or that are in the picture. So they had to have some teaching about that. Spatial arrangement and placement. The students realized that when there's 2 of them and they're both interacting with the camera, they had to get close together to each other so they could see. They realized the camera, they wanted to be positioned differently at the camera so that they would come across well on the screen. Some people would they would disappear. You wouldn't see them on the screen from outside of the room. So they had to become familiar with some of that. So positioning of where the camera is and what the patient perception of where that camera is placed and stuff are all really important considerations. So benefits. In terms of simulation value, students reported unanimous appreciation of the benefits of the simulation. And then I want to just come to some of these quotes that are kind of the most fun part, I think. So occupational therapy, some quotes. My perception definitely changed. I saw especially the med students, they were a lot more client or patient-centered than I would have thought. to be honest, that was really great to see. And then one of them recommended a swallow study to be done. And she said, they were great. They said, yeah, that's something we'll do then. We'll get a referral to speech. I literally felt like a team member. So before that, she hadn't really felt like a team member. Medicine. Some of the medical students, or one of the medical students said, I feel like on previous situations when we had nurses in the room, we treated them essentially as just a person with a piece of paper who read the vitals, and they weren't included in the simulation. So what he's referring to is for a lot of the medical simulations, they have a paid actor that goes in and plays the role of a nurse, and that person didn't really know what a nurse does. So they found it really great when we had nursing students in the room. I don't think we did a good enough job treating them as a real human nurse team member instead of previously when we treated them as just somebody who read vitals to us. Like you go to medical school thinking the doctor is going to be the most specialized person in the room, and it's good that all these other people have this much knowledge and that they can really give you a clear picture. So a little bit of respect for what nurses and other people in the room know, I think that's a great thing. Referring to expectations from previous simulations, I kind of felt like we were all playing like who has the biggest stick contest, but that participation in the simulation with other professionals was beneficial. So I think if we did more of these, it would really build more respect. Social work. I liked how there was one session without the OT, and then the next one the OT was there. It gave me and the team good insight about what their role was. So OT was in the home care simulation, and they we had some where they weren't, it wasn't possible for them to be there, and so they really developed respect for that role when it was missing. So the medical student kind of referred to social work quite a bit, and I felt appreciated. Referrals can be given to, and more information can be provided by a social worker, which meshed well in the team setting. Physical therapy students. We all have our different trains of thought because of the way we're trained. So we don't go through the same classes and courses. We don't all think alike. It's hard to learn together as a team when everybody has a different opinion and a different way that they feel it should go. So some of that struggle with trying to develop some, a shared mental model or in the team approach is kind of interesting. Nursing, because you know that. Because you know that patient. You spend more time with that patient than a lot of the other professions. So if you see them getting up and you see everything they're going through within the home situation, it's really, really important to advocate for them. It was nice when the med students would say, like, nursing, do you have anything you'd like to add to that? Like there were a couple of times when they would bring up hospice and they would say, nurses would probably explain a little bit more about hospice. So I thought it was cool how they made it a point to kind of give it back to us so we could put in our perspective. So they appreciated it. And then overall, I think this is a nice quote to just have in mind with how this experience went for kind of students overall. These are huge. They should be implemented into every medical program there is, because I came away from it and I even told classmates, this was literally the most valuable learning experience I had this semester, and I'm not kidding when I say that. In our third year in our program, we don't have a lot of hands-on, and that was a really great opportunity to have that chance to meet with the patient and other professionals. So yeah, it was incredible. So I think they liked it. So conclusions with the project for robots. Overall, CATS T-scores indicated that students were at or near competence. While telehealth initially negatively impacted coordination and situational awareness scores, it wasn't that way for the whole time. Longitudinal simulations are effective in promoting telehealth and IP skills. CATS-T shows promise for measuring those skills by including a telehealth component. And this one about integrating. It says telehealth can be integrated into existing scenarios with relatively little cost, effort, or expense. I think that's sort of partially true. There is expense to it. But in the scenarios, it's pretty much just getting an iPad, getting some sort of computer, laptop way of communicating. So one thing that they're doing in the med school now, in each of their simulation rooms, they're putting in a monitor that can be used. They already have a monitor for patient vitals and that sort of thing, but they're going to put in monitor that's got the tilting controls the pan Zoom, all of that kind of technology that's needed for telehealth, and that's going to be incorporated right in the same room so they can use it more frequently with their scenarios. And so that's what we mean by the expanded use of telehealth equipment. Future plans, healthcare professionals require education about best practice in telehealth. And that includes students, facilitators, and SIM center personnel, not just the students. We need to integrate technology into SIM rooms. We could do more work with the situational awareness that happens when we use telehealth. And right now, what we're writing is a handbook for others on how they can adapt simulations for interprofessional telehealth simulation. And I wanted to just throw this up there so you can see kind of how we schedule one of these before I take questions. So we have, this is one that was, and I know there's actual people's names in here, but they're not in the room. Right? I don't think it matters because this is in the past. But so we run the 6 rooms at a time over 1 to 5 p.m. We have to assign facilitators for each of the rooms and people in each of the control rooms. Missy has been absolutely essential to help do all of the prep for what the nursing supplies are that we need over there, because that has been huge, and then facilitates from the control room and does all of the initial orientation for students. One thing we've kind of found is we're orienting at the same time that we're debriefing the next group, and so we've had to do a lot of tag team on the orientation of students to the rooms as they come out there, because our sim rooms are different than theirs. So nursing students come in, and okay, I'll just let you take a look at that. So we have, we've kind of gone to cross-training people now, so that a medical or a nursing facilitator, you can have a nurse in the room facilitating for the med students, or you can have a doc in the room facilitating for the nursing students. We've almost had to do that because of the hours required of people to facilitate. I've now put Rashid to sleep, so we, I'm just kidding. Do we have any questions? He's not here.
No, I was just asking one question before I sleep. So,
He has to leave, so we'll take his question first.
because you are the person who is walking through with all this group, like from 1 to 2 to 3 to 5, and over the time you are seeing the same patient, same situation. Is that effect on your assessment where
Well, we have different nursing faculty in each of the rooms watching that. But yeah, I do think over time, you kind of see some patterns and see some things that you want to address differently with students when they walk into the room. So it could have a little effect on the data that they're gathering, but I don't think we really do much prep in terms of situational awareness, communication, collaboration. I don't think it affects the outcome of that tool that we're using. But
I will say though, if there's a same facilitator in each room, you do notice as you go from the 1 o'clock hour to 3, 4, things get rushed maybe towards the end. It's just, it's human nature. You've done, this is your 4th sim, you've done, and you might just hurry something along differently, your 4 o'clock sim versus your 1 o'clock sim. But that's kind of engaging.
But it is funny too how you can put, 5 students in that room and get a different outcome.
Oh yeah, there's nothing to say.
With every sim, some might get to the point of diagnosing her with an MI before, scenario is ended. I mean, that has rarely occurred, but in some of the other instances, it takes longer for them to process certain things.
And our nursing students are always, currently, not always, but we've had with our old curriculum and the new curriculum, we've had really 3 different levels of students doing these sims. So that was interesting to see our students at their different levels between the older curriculums.
We pick up on certain things, like with the younger level students where they're afraid to listen underneath the gown, and then the med students walk in the room and they actually pull the mannequin up and listen on the back side, and the nursing students kind of go, oh, I didn't know we could do that. And so, I mean, we pick up on certain things with each group that I think, I just think SIM is such a valuable place for us to learn about that because they can make those mistakes there where we can correct them and then they're not doing it with real patients. I think of all the years I did clinical and every student gets a different experience. This way we can guarantee, well, a pretty much similar experience for every student, you know, that's going through that.
I think the components that I've seen when I've worked with them, I'm interested to know first for a question is PTOT, what are their levelings? Because I know what our level is for our students. And I know the med students, a lot of times when we participate, this is prior to them going into a practice where they really integrate. So they're pretty fresh. I mean, it's really new for them. And that's good because they can kind of then role model that as they go out. Our students come pretty prepared. They've had a fair amount of clinical hours and they've seen quite a bit. What are the PTOT prep levels that participated in this? What was their year?
I really don't know.
It was second year? Okay.
There was at least between the 17 and 18, just because I happen to know a few of the students were even in the third year.
So they had got some clinical.
Mm-hmm.
Yep.
Yep. In fact, had simulations as well.
Yep.
One of the things that surprised us was in the one scenario where she's at home and at risk for developing a pressure ulcer, the OTs actually did more teaching on that than our nursing students, which surprised me.
Yeah.
I didn't know that was a big emphasis with their
And
parents.
they're in graduate program.
Sure. Yeah, that's why
You know,
I
they're-
asked, because I know that they are doctoral entry level for PT is, I think.
Yep. And
Speech.
OT is
And
just.
speech.
Desiree, does this give any ideas for how we could get nutrition involved in this?
It seems we need to. I was curious, and I know you did 2 different years. Do you do both bones where I didn't catch that? It seems kind of
For the robots, we've been doing the robots one in the fall and the spring. Now we've done 2 consecutive breast cancer ones where the first scenario comes into the ER with a breast lesion that's not been diagnosed as breast cancer, and the second scenario is end of life sim for that particular one.
I'm thinking for us, because of our schedule, we work, just one time a year. But if that could possibly work, I think it would really nicely for our senior and our fall. I should hope in the topics that I'm just hearing and the scenarios that I know about them, that there might be a role in some of those. But yeah, I'm okay because I'm interested and I know those too.
Yeah.
And I think diabetic students, and as we look to master's level, it's really important for them to be part of these types of simulation experiences.
Yeah, I can see some really even simplistic things that could be done with nutrition, just an in-hospital patient scenario. What is the dietitian in the room for? What's she going to add to this?
Care
Yeah.
about it.
And like all the times that we had to do extensive consults to get people to eat and stuff. And
Yeah, long-term care, that's one of their first placements too, so I'm thinking our students should be able to contribute to that.
Yeah.
They're actually medical. Anyway, I think there's great opportunity to have some future discussions about developing that piece of
Yeah.
learning how, you said that each group, was nursing and medicine, that you made it all together, content of that simulation, right?
well, what we had to decide on is shared goals. So we had to come up with things that we could accomplish together.
Great.
But then sometimes we had an individual checklist of things we'd expect the nurse to look for. So like when she's in there 10 minutes alone, is she listening to lung sounds? Is she listening to heart sounds? How is she interacting with the patient and the family? So you can do an individual little checklist of things you'd expected behaviors that could be things that you might look for in that scenario. But it's the timing of it that makes it kind of challenging. How much time does each profession need in the room to do what they need to do?
I know with the technology, I think it's fascinating kind of because I know the first thing that I did was a STAR workshop and we were thrown into it. We didn't really know anything about it. And I'm used to having some prep for students, but they're just like, yeah, you're going to work with a team. You don't know who's going to be there. There was a provider that I knew very well, thank goodness, because right away I connected with somebody that I knew quite a bit. And then there were 2 flight nurses from from Sanford and then there was another individual, and it was me doing the baseline assessment. And I wasn't uncomfortable with it, but as soon as the technology, I didn't know the screen and what I was doing with it.
Sure.
I felt just like, that anxiety goes up and your brain doesn't think as clear.
Right.
So I think your results are interesting to that because I was in a scenario like that. Yeah. And then there were like a few key things. We got through it and they actually taped ours and taped our debriefing because they thought we did so well. But you walked out of that not feeling that you did so well in certain components because if you've never been thrown into it like the students are, it's a whole different feeling.
Yeah.
And a whole different learning. And as soon as technology is part of it, you're kind of like, oh, if there's something I don't know about that, that's going to impact patient outcomes right away. And you get kind of a little bit, that's like when we went with the medical records online. The first year or two, you're really a little awkward. And by the time you're, pretty savvy with it, they change it, That's kind of how it is with healthcare. And so you just kind of go, oh, okay, I'm going to be able to do this, but how am I going to do this and how is it going to be best? So I think it's interesting that all of the teams, there was some amount of proficiency, like the 75% cutoff that you had, I think is great, but really expecting some of that interaction and some of that interpersonal and intrapersonal communication to drop. And I think you would expect that, and once their levels improve with that and the more exposure they have with that, that's going to be interesting to see, but I think it's really
that
important.
Experience that you had, that's what I kind of hope for every nursing student to have, because I've done that too myself when we've gone over and we do a run-through of these sims before we go in and do the actual thing. And I've been in the role of the nurse and you come away feeling just as dumb can be. But boy, then you go back and you think, well, how could I have done that better? What could I have asked her about her chest pain that I forgot to ask when I was the nurse in the scenario? So we want to get our students past that point of thinking they're an actress in the scenario into what if this really was happening for real with a real patient? What would I do? What would I say? What would I think? What would I touch? So we're really trying to make it more about what if. So.
The robots we find pretty fun to work with are kind of an interesting entry.
Well, the more technology,
so I don't know
the more technology you add to something, the more problems you have.
Yeah.
That's just
The more things can go wrong.
Yeah, that's just.
So you can have the
typical.
sound just die or the face freeze on the screen,
sure.
and so
Okay.
there are some challenges like that. So.
And even over there, having 2 full-time people involved with the technology side of things, they're still.
But then again, it gives you that opportunity to say, this is going to happen in practice. What are you going to do when it freezes? You pick up the phone and call that doc, or what do you do?
Because I imagine, especially out at rural facilities, stuff like that's going to happen all
Oh,
the
yeah.
time.
Yeah.
Bad Wi-Fi, whatever.
Yeah.
Not a lot of technology support.
Electricity just.
The
goes
wound
out.
clinic has used it for a very long time, and that's where I did my research, but we couldn't even use any of the telehealth people for our team project that we did. So I think it's an interesting component. You could look at providers that have used it a long, long time and probably learn some components of how, they would be kind of fun to be part of this too, since they've used it so long. Seth would be wonderful, I'm sure, but I don't know how you could do that if you could connect to real live telehealth.
Well, even to have them in the room as a facilitator, I think would be
wonderful.
Good to have more practicing physicians and nurses involved.
He's a graduate of our.
Thanks for your time. I know people.
Thank you. It was wonderful.
Thank you.
Okay.
Do you mind to send it to me? Because
Oh, I can.
I'd love to see that. I have a meeting with the
Oh, cool.
so I just want to see this.
Oh, sure.
If you send me today, that's a nice.
Thanks.
Thanks, Sherry. Thank you.
Thank you, Sharon.